Good morning, everyone. My name is Kara Macesso. I am the Survivorship Nurse Practitioner in the Adult Stem Cell Transplant Department at Memorial Sloan Kettering Cancer Center. I just wanted to remind you that this is designed to be an interactive session, but please hold your questions until the end. And the session is being audio recorded for those of us that couldn't be here today, so when you do ask a question, please use the microphone. And I'd like to introduce Dr. Cook, who will be your presenter today. Dr. Cook is Director of Pediatric Blood and Marrow Transplantation at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. His research focuses on understanding the mechanisms that contribute to the development of lung injury following stem cell transplantation.
Could you talk slower?
Sorry, yep. And he is recognized nationally and internationally for his work in this area. So please welcome Dr. Cook.
Thank you. Well, really a pleasure to be here. This is actually my third opportunity to speak on behalf of this fantastic program, and this is an area that has been near and dear to my heart, both from a clinical perspective and from a lab-based perspective. And I will start off by saying that in February of this year, the American Society of Blood and Marrow Transplant came together, and they had something called the State of the Science Symposium. They wanted to update everyone on where is the state of the science, clinical and laboratory for transplants in 2014. So I was really honored to be a co-chair of the one area that was looking at regimen-related toxicities. What are the long-term toxicities that patients are exposed to during transplant? And the number one toxicity remains lung problems, both acute, but not so much acute anymore within the first couple of months. Still those problems that develop months and years after transplant. So this is still a major issue. I don't know if that provides any comfort for you, but there is a focus on this, and I'm going to take you through a few things that hopefully will instill some hope that we're going to be able to manage these problems better moving forward. So I do have some disclosures. I usually start out with one that says, A, I like to talk. So everyone's always like pulling me off the podium. But and I'm a Yankee fan, but here I feel right at home. But I will be discussing this off-label use of a medicine called Enbrel or etanercept for non-infectious lung injury after transplant. And the company that makes Enbrel provided study drug and some pharmacy support for 2 multi-center clinical trials that I'll talk to you about briefly today. That support was in years past. I certainly did not receive any type of direct monetary income or laboratory-based support from Amgen, but they were very instrumental in getting these 2 clinical studies off the ground. So here are some brief objectives. To briefly highlight the concepts of bone marrow transplant and graft versus host disease. You guys are going to be all over this, but I think it's a nice way for me to warm up and to actually make sure we're all on the right page. I do think this has been, I think, reasonably well received, just reviewing basic lung anatomy, function, and testing, because if you don't really understand how the lung is working, it's more difficult to get your arms around what is going on if the lung is not functioning well. And then we'll talk about specific types of lung problems after transplant, infectious versus not, early versus late. And we'll talk a little bit about whether the lung is a true target of graft versus host disease, which I believe it is. And then in the end, we'll finish up by discussing some tests and procedures that we might need to be completed to diagnose and treat lung problems. So this is just a quick overview of bone marrow transplant. You know, back in the day when I started my training, the feeling was that, more is better. So if you give super lethal doses of chemotherapy and radiation therapy, you'd really be able to beat down some of the underlying malignant disorders for which allogeneic transplant is the only curative therapy. So this was the traditional thought. You guys may know now that we've changed this a bit, and we've begun to use reduced intensity regimens so that there's less intense chemotherapy up front. The goal was to open transplant to a broader range of folks, particularly folks in their 50s, 60s, and even 70s, and hopefully reduce some of the complications that occur post-transplant, particularly with respect to lung injury. For those of you all in the room, we know that this is no free lunch, unfortunately. It's a terrific therapeutic option, but there are many limitations to use. Regimen-related toxicity, infection, bleeding, and multi-organ dysfunction. Graft versus host disease, which I'm sure there were many sessions at this meeting on. I'm only going to touch upon this in a slide. And the development of lung injury and dysfunction, both early and late, infectious and non-infectious, and we always worry about relapse of underlying malignancy. And in fact, it's important to understand in this context the role of this graft versus host disease, which is a very complex process. And when I talk to families and patients, and I'll remind you that I'm a pediatric trained transplant doc, although I've really had the good pleasure of taking care of young adults and even adults during my career in medicine. What I talk to people about is that graft versus host disease is opposite to what occurs after a solid organ transplant, right? So if you're getting a heart, a liver, a lung, or a kidney, we're always worried about the patient's immune system rejecting the donor organ. But as I'm sure all, if not many of you know, graft versus host disease is this process flipped on then, right? It's the donor stem cell graft that can literally reject the host or patient, hence this term graft versus host disease. It is a major complication after transplant when you're using someone else other than the patient's blood cells. Can be life-threatening, major barrier to broadening the scope, always a risk unless the donor and host are identical twins. And for those of you who are I just got the goose pimples before I said this, for those of you who were at the lunch yesterday when Susan showed this great video about the history of transplant, and then they brought up the one longest living survivor. I mean, what a story that was when she received a transplant from her identical sister 51 years ago. In graft versus host disease, the damage are caused by the immune system, these cells called lymphocytes. We are going to talk about this a bit. And the target organs traditionally have been the skin, liver, and intestine, but I'm a big believer that the lung, particularly in the chronic setting, can be a target, and we're going to talk about that today. There are these beneficial graft versus leukemia effects, and in fact, treatment strategies that can reduce the damage, this collateral damage of graft versus host disease, but still facilitate the restoration of the blood in the immune systems and preserve graft versus leukemia effects are by far the holy grail. So we're trying desperately to figure out how we can best do this, because these T cells that can cause collateral damage play a big role in engraftment, immune reconstitution, and again, fighting residual leukemia. So let's move on to the topic at hand, lung problems. So when I talk to families and patients about the lung, I start off by talking about a tree. I say, think about a tree, but maybe more specifically, a tree upside down. And if you think about a tree upside down and its trunk and major branches, you can begin to understand some of the anatomy of the lung. The trunk is basically the trachea or the windpipe. The major branches of the tree are called bronchi. And the smaller twigs leading out to the places where gas is exchanged in the lung or where those leaf buds will form in the spring are called the bronchioles. And these are important terms to keep in mind, because if someone says you have bronchitis, you have inflammation of the bronchi. If you have tracheitis, you have inflammation of the trachea. Sometimes these complex medical words can actually be broken down into a very simpler form. So I go one step further and say, well, think of a tree upside down, but maybe think of a tree upside down in the spring. So again, here are your trunk, your major branches. The reason why I say in the spring is because at the very tips of these small branches are the alveoli, or those leaf buds, and they are very important for gas exchange. So here we are again looking at the lung anatomy, the trachea, the major bronchi, some of the smaller bronchi, the bronchioles, and all the way down to this small area called the alveolus. And it is there that gas is exchanged during the course of normal respiration. So what about the basics of breathing? So air travels into the lungs via that windpipe or trachea, and it goes down a series of those branching pathways called bronchi, all the way down into the bronchioles and down into those little areas called alveoli. And again, this is where gas is exchanged. Oxygen is going to be extracted out of the lungs and out of the air, and it's going to be pulled into the blood, where it's carried to the rest of the body in red blood cells. Meanwhile, carbon dioxide, a waste gas that has been produced by the body, is going to be brought back into the lungs, and that can then be exhaled. So this is the normal kind of basics of breathing, and we take for granted until we are having problems making sure we get oxygen in and carbon dioxide out. You guys are probably familiar with this machine, a pulmonary function machine. I can tell you kids are not wild about this, but with good technicians, you can really get kids excited about going into this chamber and actually getting your pulmonary function test done. So let's talk a little bit about these tests, because for those of you in the room, my guess is you've had pulmonary function tests and they haven't always looked as good as your physician or practitioner may like. So this is what we're really measuring with pulmonary function tests. Right here we'll start. We're all hopefully just breathing at what we call tidal volume. If we are excited, we could be breathing faster or more deeply, but this back and forth is called tidal volume. When you are in the chamber, they're going to ask you to take a very deep breath in and then blow out as hard as you can, as deep as you can. Then after that, you get back to normal breathing or tidal volume. What's left in your lung at the very end of that deep exhalation is called residual volume. The lungs are never completely empty. Here's that tidal volume again. We're all kind of breathing at a tidal volume pace right now. When you take that deep breath in and blow it all the way down as far as you can go, this is called forced vital capacity, or FVC. And this is one of the tests that we will spend a lot of time looking at when our patients are having lung problems. And finally, total lung capacity, or TLC, is actually the full volume of air that's in your lungs, from the most you can breathe in all the way down. If we got rid of residual volume, if you could breathe out below that, you would get all the way down to zero, which we never really can. But that kind of made-up volume is called total lung capacity. So again, here's our lung basics, our PFT. So you're in the chamber, and you're breathing at tidal volume, TV, in and out and in and out. Your coach is going to say, take a deep breath in and blow out as hard as you can and blow all that air out. This, again, from maximal inspiration to all the air out is called the FVC, or forced vital capacity. There's also a very important measurement that measures forced expiratory volume at 1 second. And this is how much air is coming out in that first second of exhalation. They can also measure forced expiratory volume at 25 to 75, which is that volume in here. But these are some of the values that your physician or practitioner is actually going to talk to you about. And again, the residual volume is what's left over after you exhale all you can. When I talk to families, I say this is kind of like a report card. Based upon your gender, your size, and your age, there are going to be some predicted measurements for any of these values. And then you're going to do the test. There's going to be a value that you actually score. That's called percent predicted. And then you're going to get this report card. I tell my patients and families, the closer you are to 100%, the better. So if you're scoring 98 or 100, you're doing great. You're scoring 65, 50, even kids in school are going to say, there's a problem there, because certainly if I bring home a 68 on a test, my mother or father are not going to be happy about that. Is this resonating with you guys? Have you seen your pulmonary function tests? You might not be an expert at reading them, but I want you to understand where some of the alphabet soup comes from. So with that in mind, let's get into some of the problems that can arise in the lung. So as I was suggesting, diffuse lung injury remains a major complication of blood stem cell transplant. It can occur in up to half of our patients, and it is unfortunately associated with significant morbidity or suffering and even direct causes of death. It can occur early or late. About 50% of the time, your physician or practitioner or nurse is going to identify some type of germ, a bacteria, a fungi, or a virus. That may be obvious to everyone. Maybe a quick strep test or something will identify a bacteria. Sometimes they're hidden. We now have very, very sophisticated tests that can look at a very low level to look for germs. But still, about 50% of the time with these meticulous tests, we can find no evidence of infection. And these are referred to in the acute within the first couple of months after transplant as idiopathic pneumonia syndrome. Idiopathic, well, we're not really sure what is going on, but you have pneumonia, and we cannot find a germ as a cause. And in the subacute or chronic setting, there are two forms of lung injury. Obstructive lung disease, where you can get air in, but you can't get air out. And this is bronchiolitis obliterans, or BO, or BROB. We'll talk about this. But there are some times when the lung actually gets stiff. It's not so much you can't get air out, you just can't get air in because the lungs are stiff, they are scarred, and they're restricted, they're tight. And that we're going to refer to as restrictive lung disease. This is a little bit of a time course. There are some causes of early lung injury that all occur within the first couple of months of transplant. Sometimes the lung can be inflamed around the time that the donor cells are coming in. That's part of engraftment syndrome. Sometimes the lungs can be inflamed and patients can cough up blood, diffuse alveolar hemorrhage. This is very scary and it can be very serious and hard to treat. And again, when the lungs are very inflamed early on, but we cannot find a form of infectious pneumonia, this is referred to IPS, or idiopathic pneumonia syndrome. Late lung injury can occur in a couple of different forms, anywhere from the first couple of months out from transplant all the way to years out. One of them called BOOP. This is a restrictive form of lung disease when the lung is stiff. The other one referred to as bronchiolitis obliterans syndrome. Some of you in the room may actually suffer from this. This is obstructive lung disease, and I'm going to give you examples of each. So let's try to characterize some of the signs and symptoms of lung dysfunction, compare and contrast the different forms of lung injury, and we'll talk briefly about what we know about the underlying cause of this. The more we know, the better we're going to be able to come up with novel approaches to prevention and treatment. How do we approach patients with lung problems? What are the current treatment strategies? And what are some of our future directions? So from an early lung dysfunction standpoint, there are lung infections. Here again is a picture of that normal bronchi. Here is a bronchi that has pus in it. This is inflamed. This is bronchitis. Sometimes smokers will have bronchitis. Sometimes I just got a call from my wife, and she has bronchitis, right? So you're on a Z-Pack, or you're started on antibiotics. Your physicians believe that there is a germ that is causing inflammation inside of that airway. What about those air sacs, the alveoli that we were talking about? If they fill with fluid and pus, then this is called pneumonia. So depending on where you are in that kind of anatomic tree of the lung, add itis, and you're going to know. Bronchitis, inflammation of the bronchi. Pneumonia is a little different, but people will use the term pneumonitis. But that is when you're down in these very important structures where gas is exchanged. And you can imagine if there's fluid or pus in there, you're not going to be able to exchange gas very well. Bacteria can be the cause, and many times your physician may have you on a drug called Levaquin to either treat or prevent bacterial infections. Fungus can also cause serious pneumonias. Sometimes you may be on fluconazole or voriconazole to treat or prevent fungal infections. Pneumocystis is a germ that can cause problems in patients whose immune system is down. That's why you might be on Bactrim or pentamidine or atovaquone. Then finally, there are a number of viruses that wreak havoc in all of us, but are particularly worrisome in patients whose immune systems are down. Many times we can do blood tests to identify viruses in the blood or in the lung washings or in your snot, actually, before problems start. So that your physician should always be thinking about the what-ifs. What are the risks involved? And many times we're trying to prevent those by either doing tests preemptively or by keeping you on antibiotics to prevent these infections. So how about non-infectious lung problems, where I've introduced this briefly? Acute lung injury is also a big problem, can be infectious or non-infectious, as we've talked. Idiopathic pneumonia syndrome is early non-infectious lung injury. Severe respiratory problems, the need for oxygen, sometimes the need for a breathing machine, generally within the first couple of weeks or months after transplant. This can be frequently fatal, with high mortality rates, and an average time to really diagnosis to not doing well very, very rapidly. The good news is that with reduced intensity transplant approaches and better matching, the incidence of this IPS disorder is decreasing, but this would be a chest x-ray of someone who's developing respiratory distress. This is the backbone here. I don't know if you can appreciate that. This is the heart. These lines here represent the rib cages. Air should be black. These lungs should be black. In fact, they're not. They're whited out. And anytime we see something like this in our transplant patients, it really makes the hair on the back of our neck stand on end. When I first started out in the early 90s taking care of transplant patients, I was very impressed by the rapid onset, speed of disease progression, and a very high mortality rate despite standard of care, which at the time just included high doses of steroids. I was also impressed how little was known about what was driving this process, and I had the opportunity with my initial mentor to study lung injury using animal models. And we'll come back to that in a little later in the discussion. Now, moving on to bronchiolitis obliterans syndrome. So BOS, or bronchiolitis obliterans, is the only manifestation of lung GVHD, as if you had biopsy-proven bronchiolitis obliterans. That was the old school definition. There are some pulmonary function test changes that can help make this diagnosis without needing a biopsy. It was first described way back in the 80s, and again, if you saw that terrific video about the history of transplant, you realize that for the first couple of decades, not many patients actually made it out of the first 100 days. So it was only when we began to have surviving patients that physicians began to identify problems in the lungs. Evidence for airway obstruction. Again, it's kind of like a fixed asthma picture. You can get air in, so your forced vital capacity or total lung capacity could be normal. The problem is when they say breathe out, the air gets stuck. It's obstructed. Patients who have asthma sometimes will use an inhaler to relax the airways and allow the air to get out. But when you have BOS, this becomes inflammatory and sometimes scarred. So we refer to it as fixed asthma. Some patients can have a dry cough or shortness of breath or wheezing. 20% have no symptoms. And this is important. We're going to touch upon this later on because I think paying attention to pulmonary function tests are very important after transplant to detect problems before they are actually clinically evident. There can be some x-ray findings. Early on, the x-ray could look normal. Sometimes there's air trapping and thickening of the airways. The onset is a little later, 6 months to 2 years after transplant. Risk factors include chronic graft versus host disease, older age, presence of pre-existing viral infections, maybe even the use of peripheral blood stem cells rather than bone marrow. Our current treatments are steroids and other immune suppressants. Azithromycin is an antibiotic that many of you may take. It is a good antibiotic, but in addition can also reduce some inflammation. So this is a drug that has been used in patients who have a BOS. It does have a significant impact, unfortunately, on morbidity and mortality. This is some of the pulmonary function or lung measurements, and here is what a biopsy would look like. So let's start over here with some of those alphabet soup terms we came up with. Forced vital capacity, FEV1. So here, forced vital capacity is 80%. I mean, that's not too shabby. It's not 100%, but it's not bad. But look at this forced expiratory volume at 1 second, 43%. That means you can get air in, but you just can't get air out. This is obstructive lung disease. And if you actually did a biopsy on a person with advanced obstructive lung disease, this is one of those little bronchioles. Do you see all of this? This is scar tissue. This is really inflammation around that small airway with a bunch of gunk inside of it. I'm going to show you a cartoon in a second. But this is why you can sometimes pull air through this, but when you're trying to get air out, it's almost like a ball valve stopgap, and you just can't get the air out, and air builds up in the lungs. So here's a cartoon of a bronchiolitis obliterans syndrome. You can have some inflammation around the airways, and sometimes you get a little bit of a mucus plug that blocks. Again, you can imagine sometimes you can get air in, but you just can't get air out, and air is going to build up in these alveolar structures. And here's the cartoon again with inflammation around the very small airways or bronchiolitis. On CAT scan, well, again, air should be black. What we're seeing here is you take a deep breath in, and on expiration, you should be able to get a lot of the air out. But there's still a fair amount of blackness. This is a subtle picture, but all of this darkness is air trapped in the lungs. It just simply can't get out. Again, this is a manifestation of obstructive lung disease. Does it have an impact on survival? Absolutely. These are data from the Fred Hutch, about 1,000 patients. If you look at patients who do not have obstructive lung disease and their overall survival versus those that do, there's a big impact here. And if you look at patients with chronic GVHD and other organ systems, again, you do see a big difference. Now,
what's that? Years, months?
This is years out from transplant. So there was a recent publication just in 2014 by Palmer and colleagues that looked at decline in lung function and noticed that, again, it predated symptoms. So many patients were asymptomatic, but they still had problems with their pulmonary function test. And it turned out that the only NIH symptom-based score was dyspnea or shortness of breath. So when you think about it, you could say, well, geez, Ken, no kidding. If I'm finally short of breath because my lungs are so inflamed or fibrotic, that's probably we're probably far down a path, and that might be a path that's difficult to actually turn around. So increasing shortness of breath score over time correlated with bad outcomes. But the issue again is you could begin to see changes in lung function well before a patient developed wheezing or cough or shortness of breath. So I actually had published a paper, kind of an editorial piece right on the heels of this to say, hey guys, this is a window of opportunity for us. Let's do pulmonary function tests a little bit more frequently. Let's identify the problem before our patient is saying, we're short of breath, we have cough, or we have wheezing. This is an opportunity for us to do something about it. Bronchiolitis obliterans organizing pneumonia, or BOOP, very similar term, but it's a much different form of lung disease. Also diffuse inflammation of the lung. Doesn't happen very often. Cough, shortness of breath, extra oxygen, sometimes fever. X-rays are a little different. I'm going to show you in a second. And more importantly, the pulmonary function tests are different too. In this case, the lungs are stiff. You just simply can't get air in. You can get air out okay, but the lungs are starting to stiffen up a bit. Occurs a little sooner after transplant. Graft versus host disease is a risk factor. This tends to respond better to steroids alone. It has been used interchangeably with this other term called bronchiolitis obliterans syndrome, which we just talked about, but they are two different problems. So here are the pulmonary function tests again. Notice the FVC. Last time it was 88 or 80. Now it's 72. Now you get the sense, that's not a normal number. FVC, again, is our ability to get air into the lungs. The FEV1, getting air out within the first second, well, that's about the same. This will never be much above your forced vital capacity. If this is down, this is going to be down too. But these are pretty much equivalent. This is a situation where the lungs are simply stiff. And again, you can get inflammation all throughout the lung tissue. And here is, again, a blockage of one of the airways. So again, it's a stiff lung, difficult to get air in. So here's a cartoon again where you can have some inflammation around the airway. Here's a small bronchiole. But now you're also getting inflammation throughout the lung. And this is making the lung stiff and heavy and is making it difficult for the patient to get air in. The CAT scans are much different. So here you see these big kind of blobs, these fluffy infiltrates. This is really goes along with significant inflammation in the lung. So what are some possible causes? And I'll speed up a little bit, but suffice to say, there can be some toxic effects of chemotherapy and radiation. There could be hidden infections, or this could be the immune system gone wild. In fact, more of this graft versus host disease, whether they're inflammatory proteins or some of the immune cells of the donor that are now going into the lung and causing problems, which begs the question, is the lung a target of graft versus host disease? And this has been a bit of a controversy. This is actually a toddler picture of my now 15-and-a-half-year-old, but kind of love this picture. So we actually use mouse models to kind of figure this out. So we actually give mice radiation and we give them bone marrow transplant, either from an identical twin or from a mismatched donor. And it turns out the animals that get identical twin transplant have beautiful looking lungs. There's no inflammation here. This is really normal lung tissue, which would look much like human tissue as well. But here's all of these purple cells are all donor immune cells infiltrating into the lungs of an animal that has graft versus host disease. And we came to find that there was a protein called tumor necrosis factor that was contributing to this process in mice. So that led to the idea, can we come up with a new form of treatment for lung injury after transplant? And it turns out, if you follow the lungs of these animals long enough, they will develop changes that are very consistent with some of those chronic forms of lung injury. So we've kind of put together, is there a phase of activity that happens in the lungs? The lungs get acutely inflamed. Maybe it's a simple cough. Maybe the patients aren't even that sick, but there's an initial inflammatory process going on in the lungs that over time kind of builds up. And instead of really just repairing itself and quiet it down, if this problem continues, many of these cells, these immune cells, can line up around the airways or perhaps get into the fishnet architecture of the lung tissue itself. And if that goes unchecked, then you end up developing fibrosis around these areas. And if it's around those small airways, you can get obstructive lung disease, but if it's all throughout the lung tissue, these lungs can be scarred and very stiff. This would be restrictive lung disease. And I can tell you guys, if you're at this point in time, it's very difficult in this day and age to treat a very stiff fibrotic lung. So we always want to try to pick our patients up early on in the process, finding out what their pulmonary function tests look like and trying to address lung problems when they come up, not waiting for the cement to settle and this dense fibrosis to take root. I mentioned this protein tumor necrosis factor. This is this medication Enbrel or etanercept that is FDA approved for some other disorders, and it blocks the activity of that protein. We actually used it in some clinical trials for patients with acute and chronic lung injury. It turns out that this medication is actually quite well tolerated compared to a sugar pill. It does have some side effects, but we thought, geez, these are really tough problems to treat, so why not introduce this medicine? And again, the medicine is here, this kind of dimeric or almost like old TV antennas that kind of bind up this protein TNF-alpha and make it inactive. And this is just an example of a patient who were developing that whiteout of the lungs. This was a patient who had severe early idiopathic pneumonia syndrome. She ultimately needed a ventilator. She was started on a clinical trial that used steroids and that medicine Enbrel. And here were her lungs 4 days later. You can get the sense that these lungs are black. These are now filled with air. This is a much more normal looking lung. We initially treated 15 patients with this drug. And when we compared them to patients who were not receiving the medicine at all, it wasn't a randomized study, but we thought we were seeing some early signs of improvement. 2/3 of our patients were getting off oxygen, and their survival was improving as well. So whether this was super or not for lung problems, we really didn't know. We actually embarked on a couple of major national trials in both adults and in kids, and we also used this medication for chronic lung injury as well. It turns out that we're just about to publish the results in the pediatric patients. This seemed to be a big splash. All the patients did get the medicine, but the study closed early because we met our endpoints. It was as successful as we had ever hoped. The adult study closed early too, but unfortunately, it closed early because we weren't able to accrue patients fast enough. We wanted to accrue about 120 patients. We ended up accruing about 30. And despite really a heroic effort from many centers throughout the country, we just simply couldn't enroll the patients in a timely fashion. So we had to close the study down. And we really weren't able to tell for sure if this drug was going to make a difference in the acute setting. We also used it in the chronic or subacute setting. Again, these patients who have bronchiolitis obliterans syndrome or BOOP. And we were, again, encouraged. Everyone received the medicine. It was about 35 patients. And it was interesting, if you compared our study to studies that were completed in the past, the outcomes of our data looked encouraging. And in fact, this medicine was well tolerated and did not have any serious infections. We gave it at 2 different schedules, either for a month or 3 months, and that didn't seem to matter. What mattered is if we got the drug on board sooner than later. It seemed to also work better for patients with obstructive rather than restrictive lung injury, but the patients who responded to the medicine clearly did better than those that didn't. So we're excited about this, but again, it wasn't a randomized trial for us to know for sure if this medicine would be a silver bullet, but we're really hoping to be able to develop such a study. So as we wind down and finish up, a couple of things to think about tests, procedures, and consultants when it comes to lung injury. History and physical exam is key, right? You need to remember to always stay in touch with your transplant group regularly, particularly if you're suffering from other complications, including graft versus host disease. They may want to assess oxygen levels. There are simple ways that you can just put a little clip on your finger and get a general idea of how much oxygen is in your blood. Pulmonary function testing, I think, is key. We're going to talk about that just a little bit more. Sometimes we may need x-rays or CAT scans if there's a signal by pulmonary function tests that something is going awry. And in that case, we may also want to consult with specialists in pulmonary medicine and maybe consider special tests, something called bronchoscopy, where a tube is put into the airway. The bronchoscopist can look around and flush fluid into the lungs, take fluid out that could be sent and test for infections. Sometimes we need to actually get a piece of tissue of the lung as well. So again, our job is to identify patients early on who are at risk for problems. If you've had a mismatched transplant, for example, or peripheral blood stem cells, you may be at higher risk for developing chronic graft versus host disease and lung injury. Meticulous and regular history and physical exams are key. Of course, the history is based upon what you guys report, so don't be shy about telling us if you're having cough or shortness of breath. Early recognition of respiratory distress is key, and we're going to go through a couple of things. But if you're having problems, we need to go down, and I'll show you in a second what we'll skip to. But if you're doing fine, I'm a big believer that we want to increase surveillance of this subclinical lung function. So dysfunction, looking at pulmonary function tests a few times per year for the first 2 years to make sure that your lung function is not starting to drift off without you knowing it. And if you identify a problem, you might want to repeat them even more frequently to identify the progression of either restrictive or obstructive lung disease. And if that continues, you will need further evaluation so we can figure out what is going on and how we might treat it. If there's an infection, then absolutely. We want to identify that and treat it appropriately. Is there evidence for systemic graft versus host disease? And if that's the case, maybe this problem involving the lungs, so steroids and other supportive care options are key. Is there a clinical trial available? Is Enbrel an option? Azithromycin. There's currently an ongoing trial with a combination of medicines called fluticasone, azithromycin, and montelukast. So you ask your physicians about this trial if you're eligible to be on it. Are there other medicines coming down the pike? So here's some pointers. Take good care of yourself. Don't smoke. I mean, if that should be right off the table. I've never been a smoker, so I know that can be easier said than done, but that's something that could be clearly under your control. That goes along for our patients and their caregivers, and stay away from crowds and individuals who are ill. Ask your physician and practitioner and nurse about pulmonary function tests. Let your team know about new breathing problems as soon as they occur, and take your prescribed medicines even when you're feeling well. The future, what does it hold in store? Well, I just was again blessed to be part of something called the Chronic GVHD Consensus Project, and I'll be finishing up here in just a moment, that was focusing on criteria for new clinical trials. So this is a real big focus. Number of smart people throughout the country working on it. This just occurred last June. So we're trying to come up with targeted clinical studies, and believe me when I tell you, lung dysfunction is going to be something that's hot on the docket. And again, the goal is to try to treat and identify people when there's still evidence of inflammation, rather than waiting until that cement has settled and the lungs have become fibrotic and stiff. So here's our summary. Lung problems are a significant problem after transplant. Both early and late complications are observed. In each scenario, the lung problems have a huge impact on overall morbidity and survival. The pathophysiology, what drives this, is complex, but we're using newer animal models to try to understand this, see if there's a connection between acute inflammation and chronic inflammation. More needs to be done clinically. We are updating the standard classification of disease. This was that NIH consensus conference I just referred to. I think we need more frequent surveillance of pulmonary function tests, and once we are finding changes in pulmonary function, we need to get our patients enrolled on clinical trials. I'd like to acknowledge the Sidney Kimmel Cancer Center at Johns Hopkins and the opportunity to lead their pediatric blood and marrow transplant program. I acknowledge the people who I've worked with over the last 2 decades that have brought many of our laboratory insights to the clinic. Certainly my hat goes out, and my heart is always open to our families and their patients who really help drive this. And our job is to make it transplant a safer and more effective procedure for all of you. And we've been blessed with some funding support over time to do this. And as I close, it always reminds me why I go to work every day. I'll share with you my secrets to success. Remain passionate and committed. Embrace teamwork and camaraderie. This is an important one for us. Find a mentor and then be one. But ultimately, my favorite, I found this in a fortune cookie: be too good to be ignored. Find your happy place. This is important too. And raise the standard. I'm all about being at programs that are going to create an environment where outstanding clinical research is really synonymous with best clinical care. So with that, I will show you some of my happy places. This is Cape May, New Jersey. I grew up 15 minutes from here. My dear mother still lives here, but love coming back to the Jersey Shore. If you've never been, it's really a terrific place. Don't worry about that MTV thing. I mean, that is part of the Jersey Shore, but if you're south of Atlantic City, It's beautiful beaches and really and really terrific summers. So thank you very much for your attention. I know I went over a little bit, but happy to take questions.
Okay, thank you, Dr. Cook. All right, so we'll open it up to questions now. I'll just ask you to keep them as succinct as possible to allow everyone an opportunity.
Yes, mainly. In terms of, as opposed to autologous, when you get your own stem cells back? Yes, for the most part, although there could be some similarities. Did you have an autologous transplant?
I had an autologous transplant, but I have a personal problem. It's probably not relevant to this, which is that I have amyloidosis in my lungs.
In your lungs.
And
after the transplant, or was that before? Was that one of the reasons?
That was the symptom that I ended up being diagnosed with multiple myeloma and having a transplant. So I did want to talk to you further. I had my transplant at University of Maryland, Dr. Bodros. Anyway.
Did the amyloidosis clear up after the transplant?
Not really, but there's some question. They're not sure. I'm certainly my lungs are functioning better.
Oh, excellent.
But I think, and they're not sure if it's going to get better or
stay stable.
This is how it's going to be.
Well, I don't know how they explained it to you. We actually did some work in mice, strangely enough, who develop not amyloidosis, but something similar to that, which is there's really a deposition of thick material in the lung that can make it very difficult to breathe. So hopefully, with your myeloma being under control or cured, some of that has actually gotten much better. I guess the question would be, has that left any residual scarring in the lung that is still causing perhaps some mild dysfunction? So maybe you've gotten rid of the inciting agent, but the lungs don't really like inflammation very much. So if they don't heal very well, maybe that is part of the issue. But I'd be delighted to talk to you more afterwards or by email or something. Yeah.
Thank you, Doctor. Actually, she asked part of the question. I am an autologous transplant survivor as well. I'm just wondering, I'm a long-standing asthmatic, and I'm just wondering if the asthma lends itself to any of this, or if I'm not really at risk simply because of the asthma.
Well, I would say for most of what I was talking about, fortunately, getting your own stem cells back will keep you from being at risk from a lot of this immune-mediated kind of immune system gone wild approach, because your cells are the ones that remain in your body and they should be comfortable with your lungs. Asthma can sometimes actually make some of these problems a little bit worse, because the lungs can be a little bit more agitated and a little bit more vulnerable to little tweaks. So if you get a cold or an infection, sometimes your asthma flares up, right? So if you already have a stiff lung, on top of which your lungs are a little bit irritated and can also kind of squeeze down on themselves, you can imagine where the combination of those two things is not a good one. The good thing about, again, classic asthma is that with inhalers, whether they're albuterol or even things like Advair, you can get medications right into the lungs to relax the lungs a little bit, get them to settle down, and then that airway obstruction is reversible. It's when it becomes stiff and irreversible that it can be a problem. But hopefully your asthma is well managed, and I'm sure you have flares with pollen and infection, particularly in the spring and the fall.
Exactly. Yeah.
But if
kind of coming into it now, I'm having a little bit of trouble breathing. Fall has always been a bad time for me. And then I constantly go between, is it asthma? Is it allergies? Is it the transplant? Is it I don't know. I just have some shortness of breath a lot. So.
And is it responsive to the medicines that you take for the
Generally,
most part?
yes.
Great. So this is, again, a perfect example. You certainly do not want to be a smoker, be around individuals who are smoking, because those things are just going to tweak your lungs a little bit more. Your lungs have told you they're quite sensitive to whether it's allergens or infections or what have you, but that's going to make your lungs be a little spastic and a little clamped down. So you want to try to avoid those things whenever possible.
Thank you.
Hi, I'm Rick Kilmer. I have what I would call periodic, mostly during allergy seasons, a cough that is persistent. Seems to be caused by a very viscous mucus that collects at the top of the lungs that I just can't get rid of. And the first time it lasted months, a 24-hour-a-day cough for months is grueling, and it seems to have lessened as I've gotten further away from transplant, which is now 7 years.
How are your pulmonary function tests, sir?
They didn't do them as frequently as I would have liked,
Yes.
but they said there was not a problem with them. Now, I don't know the numbers, though.
But that's good. I mean, if your physicians and practitioners feel that your lung function has actually been preserved, it can give you some comfort in knowing that when you finally get this mucus out, which can really be thick and tenacious, your lungs are still actually doing okay. There are a couple of medicines that if it happens again, your physicians or practitioners may consider. There are certain medicines called mucolytics that are supposed to kind of break down that thickness of the phlegm. One of them is called Mucomist. You could always ask about that. It's an inhaled treatment. Making sure you're well hydrated during those times is also key, because anytime we're a little dehydrated, we just know, our saliva gets thicker, everything gets more thick and mucousy. So keeping yourself well hydrated, avoiding things that are going to be irritants to your lungs during that time, and potentially trying to ask if there are medicines available that can thin out your mucus may give you some relief. When your lungs are irritated, have you ever used inhalers in those situations?
Yes, early on there was lowering of oxygen levels, and so they tried some inhalers. I don't know which ones they were, but they didn't seem to be that effective.
Because sometimes it's not so much wheezing, but cough. That also speaks to the fact that the airways are spasming. It's called bronchospasm, or spasming of the airways. But sometimes the classic presentation is wheezing. But sometimes cough is also a very classic presentation of that. So if that comes up again, you may ask your physicians about, would an inhaler help? Maybe if I just relax my airways a little bit, this cough would go away. Because that could be particularly troublesome, keeps you awake at night. It's very hard to do any of your tasks of daily living if you're constantly coughing. But I think the good news, if your pulmonary function tests have been preserved, that should give you some hope that you can get through these kind of acute illnesses and know that your lungs are still in pretty good shape.
But I should press to have them done more frequently so that we can follow that baseline. And
I think
see
now
if
that you're
changes.
7 years out, if you get them done and they're pretty steady, that would actually be good. I'm a big proponent of checking them more frequently early after transplant when some of these changes may actually occur. I think if you're 7 years out and you do pulmonary tests and they're pretty darn normal, you might want to consider doing them when you have one of these episodes, if you can. It may be too difficult to do for them to get an idea. Geez, these really look like asthma PFTs rather than anything else. I think if you're 7 years out and you have a good baseline pulmonary function, the chances of that changing majorly now are going to be much lower than if you were only 18 months or 2 years out from transplant. Does that make sense?
Yes, it does. Thank you. Very helpful.
Hi, can you talk about bronchiectasis? I have GVHD, and I'm 9 years out, and whether that is a GVHD created thing or is it a result of infections? Because with GVHD, I've had mycobacterium infection. There's another one that's out there all the time that everyone has in their lungs. It's like a rigula or it's a thing. It's like AER something or other.
Not Pseudomonas aeruginosa?
Yeah, that one. Yeah.
Sure.
Anyway, so you have these things that are always in your lungs because your immune system isn't working properly, and most people have them, and it doesn't do anything. But bronchiectasis, they can create bronchiectasis, but I wonder whether GVHD itself causes bronchiectasis.
So that's a great question. So bronchiectasis, the term itself means thickening of the airways, and it's thickening on X-ray or CAT scan mainly because there's inflammation around the airways, and many times there is mucus that sits down there. Now, I don't know if you've ever heard of the term cystic fibrosis. So So this is an issue where it's an inherited disorder. It's got nothing to do with transplant, but it's a genetic disorder where people have a difficult time getting this mucus up, and they too develop bronchiectasis. And I say to people all the time, I think some of our patients who have chronic graft-versus-host disease, particularly of the lungs, reminds me of patients who have CF, because the lungs get inflamed, they get thickened, there's a lot of mucus down there, and it's just difficult to get it out. And that mucus is just a hotbed for germs to kind of accumulate. Now, when we did this one study that I mentioned using this medicine, etanercept, bear with me for a second, etanercept also shuts the immune system down in a very targeted way. So before we started, we said we want to make sure patients don't have infection. So we did bronchoscopy on every single patient before they got onto the trial. And believe it or not, for every patient we wanted to enroll who had no infection, we had to bronch too, because we were finding patients just like yourself, dear, who looked well, didn't have fever, maybe a little bit of a cough, but we went down into the lungs and we were pulling out Aspergillus, Pseudomonas, mycobacteria, and we were like, holy smokes. Firstly, we're not going to put these patients on a new medicine, or new to this area, that may affect the immune system. But then we were left with, what do we do? Patient doesn't have fever, but you don't want these germs sitting down in your lungs knowing that they can cause problems. So it is a big issue, but I think making sure that when you identify some of these serious players, you may talk to your physicians about treating that even if you're feeling good, because you don't want to end up developing an acute pneumonia with one of these really tough organisms, because they can be really tricky to treat if they're really out of control. But I think it is a component of graft-versus-host disease. It's chronic inflammation, the buildup of mucus, the thickening of those bronchial walls, and with that mucus, germs that you're usually used to kind of coughing up and getting out can kind of sit there, and it can be a hotbed for germs there. So are you on any medications currently that are helping kind of...
What I do is I just every day, in fact, I got one of those vests.
Mm-hmm. Yeah.
But that,
the vibratory vest, does that help?
That cause, where I invert myself, I do plow and shoulder stand, and I just cough up all this mucus every day.
And you get it out.
And I get it out. And I mean, I've been doing pretty well, but it's kind of a weird problem. And it's because this stuff is all sitting there ready to create an infection.
Yes, absolutely. Where are you treated, dear?
I'm at Tufts Medical Center,
yeah, sure.
Boston.
I mean, I'm sure you've talked to your physicians about that, but there are sometimes you can rotate antibiotics around a little bit to try to, you don't want to keep one antibiotic on for too long, because then germs can kind of outsmart that. But if there are times where you're really not feeling well or developing a fever, I'm sure you want to talk to them, because if they've identified germs in your lung, they want to be probably a little bit more proactive about treating a bit more aggressively. But I like your approach to what's called postural drainage. You know, sometimes those vests help with that, but sometimes it's maybe, standing on your head and getting that stuff out.
Stand on your head.
That can actually
drains
help.
out. Because someone described to me that the mucus elevator in your lungs is broken.
Mm-hmm.
It's stuck in the basement.
That's right. That's right. No, that's absolutely right. We take for granted that that elevator gets mucus and germs out, but when it's not functioning well, it can be a problem.
Probably have time for about 2 more questions.
Hi. I just completed the FAM
Yes.
study, and my doctor feels it was a success because I was stabilized. I now currently, a few weeks ago, he did a throat culture, and I had a viral infection in my throat, a common cold, he said. But I've been coughing now for 6+ weeks. And I had an x-ray, and I had a CAT scan, and the x-ray, they saw a shadow, and they were concerned. That's why they had the CAT scan. The CAT scan, they feel that the shadow was a cracked rib, because I've been on steroids for quite some time. But I guess my question is, I really can't do steroids any longer, because I'm not mobile. I'm almost totally not mobile from the steroids. So where do I go from here? Is Imbro something to consider? It's the expiration is the problem that I have.
So I sympathize with what you're going through, but in going through some of these slides, you're a perfect example of going down all of those things, having the diagnosis, the x-rays, the CAT scans. Have you ever had this bronchoscopy done too? Have they ever looked to...
No. I do have the pulmonary tests about every 6 weeks.
Yeah. So that identification, being on a clinical trial, so you get the flow of what we're trying to do. When we use the etanercept medication, we actually weren't looking... If you were stable, you weren't counted as a success. So we actually had to have patients show improvement on pulmonary function tests. But you are absolutely correct that on the FAM trial, if patients are steady, they're counting those patients as a success. And I don't think that's a bad thing necessarily, but there was some additional stringency to the etanercept trial. That medication is FDA approved and it's available. If it's early on in the process, because it will suppress the immune system, if you already have scar tissue, the medicine probably won't work so well. But if you still have active inflammation, that may be something to consider. And if you wanted to talk to your physician, if they wanted to reach out to me, I'd be happy to send them the paper that we published, the work that we've done on this, to see whether or not it was a reasonable thing to do. It can sometimes steroids spare, right? Because steroids are going to make your legs weak. It's going to make your bones thin.
I got osteoporosis in 10 months. I went from slight osteopenia to osteoporosis like that.
I mean, steroids are, really have such a significant double edge. They're a very potent medicine for us, but the side effects can really be can really be a problem. So if you're interested, where are you treated, dear?
North Shore LIJ and Cornell in Presbyterian.
Sure. So I'm sure you're going to be in great hands. If you wanted to talk to your physicians about this meeting, I'd be happy to speak with them or email with them.
Okay. And quickly, photokinesis?
Photophoresis.
Phoresis, sorry.
Great question as well. There's some evidence that maybe photophoresis can help the lungs. It's a little hit or miss. Excellent for skin thickness. Excellent for skin rashes, skin graft versus host disease in the chronic form. It's actually a procedure wherein your blood cells are pulled out of your body. They're actually your blood is placed in a grid. You're asked to take a medicinal agent that sensitizes the blood cells to UV light, and the cells themselves are treated outside of the body with UV light, and then the cells are put back into the body. No one really knows how it works, but it does kind of change around some of the blood cells in a way that quiets down the immune system. And it's actually thought to be an effective treatment for graft versus host disease. There was just another big national trial where we thought we would get that answer. That trial unfortunately failed to accrue speedily enough excuse me, to keep it open. So we still don't know for certain if that would be an absolute effective treatment, but it is used with some frequency for skin graft versus host disease, and there are reports that it could potentially help the lungs, but they're more anecdotal than anything else.
Thank you for all your thoughts.
Oh, my pleasure.
So I've had 2 transplants, 7 years out of the second one. I have a lot of GVH, and I have bronchiolitis obliterans, and I'm on 7 different things for it. But my question to you is, other than medications, what other things can we do besides stand on our head? Which I don't think I could do, but physical things.
Yes.
To help with the breathing.
So another great question. I think trying to do the best you can to stay physically fit. Now, what does that mean? Again, you want to try to avoid things that are going to inflame your lungs. Smoking is, again, a number one. I think there are things called incentive spirometers. You guys may have seen these before. They're little plastic gizmos that actually do help exercise your lungs to some degree. I would absolutely try to ask your physician for something like that. I mean, incentive spirometer. Yeah.
Those things you breathe into, right?
That's right. That's right. You never. Yeah. And it's something that really, it's an exercise for the lungs. Sometimes the vests can actually be very helpful. It depends a little bit perhaps on your body habitus or how it feels, but sometimes that vibratory nature of the vest can help actually clear some of the mucus.
What are the vests? What are they called?
Do you remember, dear?
The vest.
The vest.
And it's made by Hill.
Yeah, they're vibratory vests. You put them on, and they basically, you know, they vibrate like almost like a massage, I guess. But it does help. It's
A life jacket.
yeah, it helps with
Pumps up.
Sort of shakes things.
yeah, shakes things up.
It just vibrates on you.
Yeah, I mean, it helps kind of try to facilitate getting some of that mucus out. If you need oxygen at certain times during the day or during the evening, I think that's important too, because you never want to be running too low on oxygen. That can kind of slow you down a little bit and tire you out. I think if there are ways that you can otherwise stay physically active, even if it's through walking, now sometimes that can be tricky, but the better cardiovascular shape you put yourself in, that can also be helpful, I believe, with lung impairment as well. So I'm sorry that wasn't any silver bullet per se. I also do think that if you're on steroids, good bone health is very important. You should be talking to your physicians and practitioners about vitamin D and calcium supplements. Rarely we will use bone building agents, but you know, once you have osteoporosis and you're prone to fractured ribs, other broken bones, that can unfortunately put you in a vicious cycle where you become less and less mobile, and that makes you more and more in bad shape, if you will, cardiovascular shape. So those are other things that you can do to try to keep yourself healthy otherwise.
So we were in the last 2 days we were in Rome, and we all got some kind of cold or something. So mine went to my lungs, and I said to my husband, I have to go and just get a nebulizer treatment. Went to this hospital in Rome. I don't speak Italian. It was like a teaching hospital. They were so interested in the fact that I had bone marrow transplants and bronchiolitis obliterans, and I got so much attention. I didn't have to pay anything, and I was, and I was trying to explain in, English and a little bit of Italian to people who had fractured English,
Funny.
like what was going on. But they were delighted. They were like, "Stay 2 days."
Well, always better to better when you walk in and they look at you like you have 3 heads when you tell them you've had a bone marrow transplant, right? That's always unnerving. Well, thank you very much. I hope this was helpful to you, and I hope you enjoyed the meeting.